let's continue on and get into cranial tumors. Okay, three different kinds of cranial tumors that we're going to talk about is the astrocytoma, the schwannoma, and the ependymoma. Okay, so let's get right into that with the astrocytoma. Okay, astrocytoma, it is the most common glioma, which means that there is a very, very common cells, astrocytes and glial cells, obviously in the brain, and this is the most common. Okay, what's odd about that is when we get to the most common glioma, and it's associated with its stage 4 glioblastoma multiforme. So we'll see that in a second here, but let's first go back up a little to the astrocytoma in general. Usually you're talking about fairly young people that get these, in between the ages of 20 to over 45, but fairly young people that get these. 4 grades of astrocytoma, going from low to high grade, and from the onset of symptoms to diagnosis in a low grade is about 3.5 years. Okay, it's a low grade astrocytoma in general. Okay, what happens is you have headaches because there's something in your brain. Obviously, you can see that. Irritability, personality changes, depending on where it is in your brain, of course. Increased intracranial pressure. There's something in there kind of acting a little bit like a subdural hematoma or something, because something is growing in an enclosed space with a hard shell around it. Now, getting to that grade 4 part of it, so this astrocytoma, when it basically jumps from a stage 2 astrocytoma really fast to a grade 4, and at grade 4 astrocytoma they call a glioblastoma multiforme, and that's that, glioblastoma multiforme. Poor prognosis once you get this. You're talking about 14 months. That's what we're really looking at here on these tumors, is the stage 4 or glioblastoma multiforme, and you can see that they're huge, they're enormous, they grow incredibly fast. This is the one that breaks the rule, like I was talking about before. Most common primary brain tumor is astrocytoma. Grade 4 astrocytoma glioblastoma multiforme is also the most deadly primary brain tumor by far. Okay, again, poor prognosis, 14 months. In reality, a lot of people will have been diagnosed with the glioblastoma multiforme because they have these symptoms mentioned above: personality changes, maybe some clear liquid running from their nose. They might think that they have a runny nose for a month or so, and they get headaches, and all of a sudden they get taken into the hospital because they're completely abnormal. They're out of it. They're not quite there, making things up, and the next thing you know, they got 3 to 6 months to live. So that's unfortunately not uncommon. All right. Let's move on to another intracranial tumor, or intraspinal also. It's called the schwannoma. Schwann cells, remember those, that they put the myelin on the peripheral nerves? Okay, so now we get an overproduction of Schwann cells. Again, fairly young, ages 30 to 60. These are benign tumors, okay, but well, they're idiopathic. Really don't know why for sure. Maybe some genetics involved in that. But the interesting thing about the schwannomas is what it does. So it affects your hearing and equilibrium. Well, why does it affect your hearing and equilibrium? Because the one that we're talking about most of the time when we're talking about schwannomas is the specific acoustic neuroma, acoustic as in sound. Neuroma, that's cranial nerve 8. If you remember, cranial nerve 8 is the vestibulocochlear nerve, as in it goes to the vestibule that goes to the semicircular canals in your inner ear for your balance, equilibrium, and the cochlear part of it goes into the cochlea for hearing. So you can see where you'd have hearing and equilibrium problems with the specific acoustic neuroma. However, the schwannoma can affect all cranial nerves all the way, well, not all of them, but 3 through 12. So you can see any kind of different manifestations as far as that goes. Okay, if you look at the pictures here, this is probably not very helpful to you, but you know, they grow and they're encapsulated. They're not really going anywhere. If you look here, this is obviously on a spinal cord, and you can see that very well encapsulated, not going anywhere. But clearly, if that's pressing on your spinal cord, you're going to have some issues from that. Okay, guess I didn't need to do that. Okay, ependymoma. Okay, these come from the ependymal cells. If you do not remember ependymal cells from your earlier bio classes, ependymal cells are the ones that make cerebrospinal fluid. Okay, they make that choroid plexus and the ventricles, and then make cerebrospinal fluid, because that's what they do. They line the ventricles. So these ependymal cells lining your ventricles, as you can see, if you have a tumor arising from that, then you're going to have flow problems with your cerebrospinal fluid. Okay, this typically affects young children. Okay, so intracranial, young children, 4 years, but 25 to 40% are under 2 years. Okay, so this is a little kid's brain tumor. Okay, you often find them in the fourth ventricle. That's the one that's in the back of the head, over there by that cerebellum back here, and cerebellum right here. And you see them in the fourth ventricle area, which is all around this area really. And it can go all the way up through the top of the brain and you know, back into the arachnoid villi, how everything's getting back in there, how the cerebrospinal fluid is flowing. So if you remember, maybe or maybe not, you know, you have your lateral ventricles up in the front, dropping down into the third ventricle, going through a cerebral aqueduct, and then coming into, go down the spinal cord, and then back up around and back into the brain. So you'll see these in the fourth ventricle typically. Anyway, obviously you can see where if you have a big old tumors stuck in this whole system where cerebrospinal fluid is flowing, it can cause a blockage of that, and therefore lead to hydrocephalus, or a lot of water in the brain. Okay, nausea and vomiting because of that increased intracranial pressure, impaired motor function, again because of the pressure and all that sort of, and the things that go along with it. Okay, let's look at some neurological tumors here. Okay, neurological tumors, meningioma, okay, as in meningitis, as in the meninges. Okay, usually about 90% of the times, like it says right there, it's benign. It's encapsulated. It's not going anywhere. This is the most common primary central nervous system tumor. Remember, the glioblastoma multiforme, or the astrocytoma, is the most common primary intracranial tumor. This one's for the central nervous system itself, and it fits the rules, right? 90% of the time they're benign, most common benign. If the rule was the other way around, as we see in the glioblastoma multiforme earlier, then we wouldn't live very long, because most common would be deadly and nobody be around. So this fits the rule, makes us feel a little better with that. Ages are a little higher up there, right? So 40s to 70s, middle-aged women seem to be a target with these meningiomas. Radiation, of course, genetic factors, probably. Okay, so again, if just like any kind of growth, if this one is, for example, the meningioma happens to be in the meninges in the brain here, inside the skull, you can see where it looks a lot like the effects that you would have again on a subdural hematoma, where if this thing is growing inside, it's pushing brain matter, it's causing intracranial pressure, and even though this is a good example of a benign tumor that can certainly kill people. Okay, it says here is blocking the ventricles before it's displacing, brain compressed and displaced. Okay, so it's pushing it. You can see in that picture, it's pushing it over. You can see here it's going the other way. If you look at this line right here, it's pushing everything that way, and this one is pushing everything that way. Okay, compressing arteries and nerves, good picture of that. Okay, because it can't go anywhere. Yes, because of that hard skull. Okay, oligodendroglioma. Okay, well, that would have to do probably with our oligodendrocytes, which are also making the myelin, but that's in the central nervous system. So the oligodendroglioma, about a third of them are malignant. It is pretty slow growing, and it presents as a seizure. Not that a lot of tumors don't present as seizures, but this one is kind of known for presenting as a seizure. Young and middle-aged adults, usually the history of epilepsy because of, you know, what it's doing. And again, most of the time they are benign, 2/3 of the time encapsulated, so you have a better prognosis because they're not metastasizing anywhere, as opposed to when I was talking about that glioblastoma multiforme. I guess I didn't mention that, but with a glioblastoma multiforme, it sends out little shoots or seeds, like we talked about earlier, so the glioblastoma multiforme will send out a shoot really fast and seed somewhere else and grow another tumor, and then it's almost impossible to track down and catch because it seeds so fast. By the time you remove one tumor, another one's popped up somewhere else, and that's why it's so fatal, so fast all the time. Total opposite of this oligodendroglioma, you can usually catch it and get rid of it. Okay, move on to spinal cord tumors, specifically spinal cord tumors. As you can see here, this one down here looks a lot like our encapsulated benign tumor that we just saw a little bit ago, right? Okay, anyway. Extradural, as in outside the dura mater, intradural, inside the dura mater, and intramedullary. Okay, let's look at these different kinds one at a time here. So the extradural spinal cord tumors, most are metastatic carcinomas of the lungs, breast, prostate, kidneys, thyroid, or lymphomas. Okay, so these things are coming from other places and metastasizing into the spinal cord outside the dural layer. Okay, they can affect your vertebrae, of course, because they're pressing on it. And osteosarcoma and Ewing sarcoma, you see most commonly in kids. These are the ones affecting the bones, all right, directly, as in cancer of the bones is when you see these osteosarcoma and Ewing sarcoma. So don't get these confused with the metastatic ones. These are their own extradural spinal cord tumors. Okay, intradural, good news is most of the ones intradural are benign. Okay, like I said, meningiomas and neurofibromas are another one, gliomas in general. Okay, these things, because they're inside that dural layer, they can get inside, infiltrate, and destroy your actual spinal cord parenchyma. Okay, so that's obviously, even though they're benign, not a good place to have them, certainly. Alrighty, and you can see here in this little picture, it's a spinal cord tumor that looks a lot like the MRI here. Alrighty, intramedullary, back to this astrocytoma, most common kids and teens for these astrocytomas. Again, we're not talking about glioblastoma multiforme in these cases. Okay, that's specifically astrocytes in the brain that goes wacky. Alright, signs and symptoms, clearly, if these are in your spinal cord, it can cause back pain and changes in sensation and paralysis, scoliosis, you know, twisting of the bone going the wrong way, bowel and bladder incontinence, especially if they're lower down in the spinal cord. So those kind of all make sense. You kind of figure those out anyway just because there's something in your spinal cord. Okay. Facial tumors. These are a bit nasty, right? Mouth, lip, tongue cancers. Most of these things are unfortunately, from choices people are making. Most of the time, you're just smoking and getting these mouth cancers, or chewing tobacco is a huge one. You know, some some from alcohol, sun damage, radiation, things like that. But most of the time, unfortunately, you're talking about chewing tobacco, and this slide right here isn't even close to some of the incredibly nasty things that you will see in some of these facial tumors. But clearly, even something like this you don't want on your face. Okay, so it's not worth it to chew tobacco, I guess is what I'm saying. Okay, what's it look like? It looks like a little lump or a sore. It just never gets better. Okay, so you can tell it's cancerous when it just never heals. It just continues to bleed and bleed and bleed. Every once in a while, by the way, you get loose teeth. You get HPV, as in human papillomavirus 16, causative agent of oral cancers in non-smoking youth. So sometimes HPV is responsible for these two in the face. Moving on to tumors of the neck. Okay, a lot of different reasons for getting tumors in the neck. Radiation is a big one. There's certainly genetic components for thyroid cancer when we're talking about getting tumors in the thyroid. You kind of have to break this up, because when you're talking about thyroid cancer, cancer in your thyroid, it really depends on what kind you're talking about. Okay, so if it's papillary cancer, papillary thyroid cancer, then it's good. Fortunately, it's the most common and the highest cure rate with that. On the other hand, if you have anaplastic thyroid cancer, that one is pretty rare, but it has a really poor prognosis also. There was a movie about some guy that had that. I can't remember the movie, though. It was a long time ago. Anyway, he was a doctor, and he died really fast. Like I said before, it says right here again, anaplasia, loss of differentiation, cells revert to less differentiated form, as in they're all messed up. They don't look like anything that they should have looked like before. Increased female, so more females and over 30 is when you tend to see these thyroid cancers. And obviously it'll cause a nodule because you have a cancer there, and hoarseness because it's pressing on your voice box under there. Dysphagia, neck pain, lymphadenopathy. Nothing that you wouldn't expect there, I suppose, if you were talking about any kind of cancer in your throat. Esophageal cancer. All right, well, what's going on in here? You got a couple of different kinds of esophageal cancer, and it really depends on which type of esophageal cancer someone is more likely to get based on what they're doing to get the cancer. For example, if you look at squamous cell carcinoma, okay, you start out with stratified squamous cells in the esophagus to start with. Well, when you get cancer in the squamous cells themselves, about half of that, they linked it directly to smoking. Okay, so that's the one that is their throat cancer from smoking. On the other hand, if you look at the adenocarcinoma, then that one is, you see it more from the whole, you got GERD, okay, gastroesophageal reflux disease, untreated acid reflux into your esophagus. After a while can cause Barrett's esophagus. After a while, that Barrett's esophagus can turn into the adenocarcinoma. Remember, the adeno part of it was from glandular tissues. Okay, so that adenocarcinoma will come from the lower part of the esophagus, from the glandular tissues, and it's also not very good either to have. Obviously, throat cancer of any kind is not a good thing. Okay, typically older males. Radiation is always a problem. Dry cleaning chemicals is linked to esophageal cancer. Heavy fumes, lye, like from lye soap, it's a very caustic or burning agent. Okay, I already talked about smoking. Alcohol, of course, can damage that epithelium and cause cancer too after a long time. Chronic GERD, obesity. Yeah, just because obesity actually leads to reflux disease in the first place, as does diet. Okay, but all this kind of stuff that you would see if you had any kind of throat cancer again. And achalasia, lower esophageal sphincter fails to relax, and aperistalsis of distal 2/3. Okay, so basically it's the inability to swallow because your peristalsis is not working, that thing that kind of grabs the food and pushes it down. Okay, well, if you can't get the lower esophageal sphincter to relax and you lose your peristalsis, then you can see where that's going to certainly cause a backflow of everything and a stoppage of it real fast. Okay, it's a good place to stop. I've been about 20 minutes into this, and then we'll get into lung cancer on the next video.